Welcome to This Explainer. Today, we're unpacking something that sounds incredibly scary, heart failure. But right off the bat, we've got to reframe that term. It's not this abrupt, sudden halt where the heart just stops. It's actually a progressive, really grueling mechanical struggle. Let's get into it. So what really happens when the heart fails? When you hear those words, it's super easy to picture a machine just suddenly powering down, right? But the truth? It is way more dramatic than that. It's not just an off switch. It's the beginning of a desperate, microscopic internal battle where the body's very own defense mechanisms accidentally become its absolute worst enemies. All right, first things first, let's establish exactly what we're dealing with here. Medically speaking, heart failure is a complex syndrome. It comes from any structural or functional impairment that basically stops the heart from adequately pumping blood. And this is highly progressive. The American College of Cardiology and the American Heart Association classify it into 4 distinct stages. We're talking stage A, where a patient is simply at a high risk, all the way down to stage D, which features advanced structural disease and symptoms even when the person is completely at rest. Here's our roadmap for this explainer. We're going to break this all down into 5 logical pieces. First, what is heart failure? Second, the mechanics of the heart. Third, the types of dysfunction. Fourth, the compensatory mechanisms, those biological saboteurs I just mentioned. And fifth, the symptoms and acute crises. All right, let's jump right into section 1. What is heart failure? To really grasp a failing heart, we have to look at what a healthy heart does in everyday life. This brings us to a concept called cardiac reserve. Basically, your heart's extra gear. Think about a healthy athlete. They've got a massive cardiac reserve. They can ramp up their output by 5 or 6 times during a full-on sprint. But a patient with heart failure? It's a completely different story. Their heart is so compromised that they are tapping into that emergency reserve just to sit still. Climbing a single flight of stairs literally exhausts whatever little they have left, leaving them totally breathless. Moving right along to section 2, the mechanics of the heart. We're going to pop the hood and look at the plumbing and pressure of our body's most vital and overworked pump. Okay, to understand this pump, you really have to understand its 3 mechanical pillars. First up is preload. Think of this like water filling up a tank. It's the volume of blood stretching the heart muscle at the very end of its resting phase, right before it gives a big squeeze. Second is afterload. If preload is the water in the tank, afterload is the resistance in the pipes that the pump actually has to push against. So if a patient has high blood pressure, man, that afterload is immense. And finally, contractility. This is the raw horsepower of the pump itself. It's the ability of the heart muscle fibers to actually contract and generate that pushing force. Now, if we zoom all the way down to the cellular level, we can see how this horsepower actually triggers. And it is all about calcium. Basically, an electrical signal sparks this massive rush of calcium ions from outside the cell and from internal storage units. This calcium literally acts like a key, unlocking protein fibers so they can slide past each other. That microscopic chemical spark is exactly what physically creates every single heartbeat. It's honestly kind of amazing. Which brings us to section 3, types of dysfunction. Because when this beautiful mechanical system breaks down, it doesn't just fail in one single way. Right, so the pump can actually fail in 2 completely distinct ways, and understanding the difference here is absolutely vital. On one hand, we have systolic dysfunction. This is a heart that is just too weak to squeeze. The muscle has lost its contractility, and the ejection fraction, which is the percentage of blood it can pump out, drops way below 40%. On the other hand, we have diastolic dysfunction. Now here, the heart can squeeze just fine, meaning the ejection fraction looks totally normal. But the catch? The muscle is way too stiff to relax, and because it can't relax, it can't fill up properly. Obviously, a pump that can't fill has absolutely nothing to pump out. And because the heart is actually a double pump, the clinical reality for the patient depends entirely on which side fails. If the right ventricle fails, blood backs up into the body. Fluid starts pooling in the liver, the GI tract, and gravity pulls it down into the legs, causing some pretty severe swelling. But what if the left ventricle, the side that pumps blood out to the whole body, fails? Well, blood backs up in the exact opposite direction. It goes straight into the lungs, flooding them with fluid and causing some really terrifying breathing issues. Now for section 4, compensatory mechanisms. This is essentially the climax of our biological narrative. So when the heart begins to fail and its output drops, the body definitely notices. The nervous system and the kidneys detect this crisis, and thinking the body is literally bleeding out, they slam the panic button. They send in the emergency responders. The nervous system floods the heart with adrenaline, practically whipping a weakened heart to beat faster and harder.
Meanwhile, the kidneys start hoarding salt and water to boost blood volume. But here is the tragedy. Forcing a broken pump to beat faster, while simultaneously flooding the system with excess fluid, it is catastrophic. These responders act as saboteurs. They're emergency workers who just do not know when to quit.
The kidneys execute this sabotage through something called the RAS cascade. It starts when they detect that low blood flow and release an enzyme called renin. This sparks a crazy chain reaction, eventually creating something called angiotensin II. Now, this aggressively constricts blood vessels, basically clamping down on the pipes. Finally, it triggers aldosterone, which commands the body to retain massive amounts of sodium and water. So you're getting a terrifying domino effect of escalating pressure and fluid. And this brings us to the really tragic irony of the Frank Starling mechanism. The theory here is that stretching a muscle fiber makes it contract with more force, kind of like pulling back a rubber band. So when the kidneys add all that extra fluid, the heart stretches, and sure enough, initially it does pump a little bit better. But there is a breaking point. Overstretch that rubber band, and the muscle wall tension skyrockets. The heart demands vastly more oxygen and ends up failing even faster, causing its function to completely plummet.
Let's transition over to our final section, symptoms and acute crises. We've seen the microscopic battles, right? Now let's look at how they create these terrifying macroscopic realities for the patient. Over time, all this constant stress physically deforms the heart muscle. In concentric hypertrophy, which is caused by pushing against super high pressure, the muscle walls actually thicken inwards, and that dangerously shrinks the chamber size. Then there's eccentric hypertrophy, caused by constant fluid overload. Here, the walls stretch out, becoming thin and dangerously dilated. The heart is quite literally changing its shape just to survive. But unfortunately, that deformation ruins its ability to pump. And when the left side of the heart fails to keep up, it can cause acute pulmonary edema. Normally, the pressure inside your pulmonary capillaries is pretty low. But as blood backs up from that failing left ventricle, pressure in these tiny vessels spikes. When this filtration pressure exceeds the forces holding fluid in the blood, plasma is violently pushed directly into the air sacs. The patient, tragically, begins to drown in their own fluids. So all of this results in a frankly brutal array of physical symptoms. Patients suffer from dyspnea, which is severe breathlessness upon the slightest exertion. They experience orthopnea, which is fascinatingly terrifying. Basically, when they lie flat in bed, gravity is no longer keeping the excess fluid down in their legs, so it redistributes straight into their lungs, literally forcing them to sleep sitting up. They might even develop Cheyne-Stokes respirations, a cycle of deep breathing followed by just completely stopping breathing during sleep. Add to all this massive peripheral swelling in the legs and a profound, life-altering fatigue simply because their brain and muscles are totally starved of oxygen. So I want to leave you with this thought. How does recognizing these biological saboteurs change how we actually treat and live with heart disease? Well, suddenly, medical treatments make perfect sense. Diuretics drain that flooded tank. ACE inhibitors and beta blockers, they don't stimulate the heart, they actually quiet down the panic-stricken kidneys and nervous system. Treatment is really all about disarming those well-intentioned saboteurs to give the struggling heart a chance to rest. Thank you so much for joining me for this explainer, and definitely keep questioning how our incredible bodies really work.